It's a pleasure to speak to the patients and family members and caregivers, as well as healthcare professionals regarding medulloblastoma, which has been, I would say, the poster child for how to make progress in pediatric brain tumors. The title of my talk is New Insights into Diagnosing and Treating Medulloblastoma. This is an outline of my talk. I'm going to first give an overview of how we arrived at our current management strategies. I'm going to explain what are the current challenges for high-risk patients. I'm going to review the exciting new molecular classification for medulloblastoma and how that's going to impact future therapies, and then briefly discuss whether there's a role for what we call megatherapy or high-dose chemotherapy with stem cell rescue. I have some disclosures, but none are relevant to this presentation. And just as a word of disclosure, some of the figures have been taken from Dr. Vogel's illustrated surgical pathology. Cause of death after accidents and trauma. And once we look at all cancers in children, the most common is childhood acute lymphoblastic leukemia. But when you remove that and put all the pediatric brain tumors together, regardless of their histology, it's the most frequent diagnosis. Drilling down further into the pediatric brain tumors, although more are low-grade than high-grade, the most common malignant brain tumor is medulloblastoma, and is designated as a World Health Organization grade 4 tumor, where grade 4 tumors are considered the most malignant or aggressive. However, malignant does not mean that they are not curable, as you will see. So in the United States, there are about 22 or 2,300 new brain tumors a year, and that translates into up to 250 new children a year in Canada with a brain tumor. And if you look at the numbers, about half will be gliomas, and 20% will be what we call embryonal tumors, or tumors that arise out of what we consider normal developmental processes, and medulloblastoma is included in that group. About 10% are ependymoma, and there's a miscellaneous group. One looks a little more closely at the glioma group. As I mentioned previously, the low grade are more prevalent than the high grade, and so in Canada we only see about 30 children a year with a high grade glioma and anaplastic astrocytoma or glioblastoma, which is very different than what we see in adults, where the majority of patients have malignant gliomas. In our pediatric patients, the majority occur during the usual childhood years, but there's a significant minority of patients who have a brain tumor presenting in the first 3 years of life, and this is how we describe infants for the purposes of neuro-oncology. Many patients often ask, what are the risk factors for a brain tumor in childhood or adults? And there are very few cases that run in families. We have a few tumor predisposition syndromes, the most common of which is type 1 neurofibromatosis, occurring in about 1 in 3,000 patients. However, the vast majority of patients do not have any risk factors apart from one. If one was born and received radiation from a nuclear accident such as Chernobyl, we do know that there's an increased risk of all sorts of malignancies, including gliomas and meningiomas. In fact, childhood leukemia survivors treated 1 or 2 decades ago often had cranial radiation at a low dose, and we're now seeing those survivors 10, 20, 30 years later with meningiomas. And patients who've had radiation previously may be at risk for subsequent tumors. The key thing here is a latency period which refers to the time one sees the disease and looking back at when the risk factor occurred. So these do not happen within 1 or 2 years. As pathologists look at these tumors, it's rather complex, and in order to simplify it, one has to think that the brain is made out of different cell types. There are the glial cells, which include astrocytes and oligodendrocytes, as well as ependymal cells, and each of these can have tumors. One also sees the choroid plexus, which makes cerebrospinal fluid, and then there are the neuronal cell types, and we use the term embryonal to mean tumors that arise out of developing tissues. So the tumors that we often think about or we see in children are the low-grade astrocytomas. In adults, we tend to see the high-grade astrocytomas and oligodendroglial tumors. But in children, we may see embryonal tumors, including medulloblastoma, which is today's topic, as well as some unrelated disorders that have in the past been confused with medulloblastoma, including atypical pterygoid rhabdoid tumors and primitive neuroectodermal tumors. So this is a pie chart or brain chart adapted from Victor Levin's book from over 15 years ago. It shows the relative incidence of brain tumors in adults. And as you can see here, the vast majority of them are the malignant glioblastomas or infiltrative astrocytomas. However, a small percentage of adults will have other types of brain tumors that we would most commonly see in children, including medulloblastoma. If one looks at the numbers, however, up to 20 or 25% of all medulloblastomas occur in the adult age range, meaning those 18 years of age and over. And this is a pie chart for pediatric brain tumors, and as you can see here, the majority of these patients are not malignant glial tumors, but there's still a significant number of low-grade gliomas. Medulloblastomas are 15 to 20% of the population total, and a significant proportion of them of the tumors arising in the posterior fossa, which is the back of the brain, and I'll show you that in a moment. Other tumors that can occur there include the ependymoma and a pilocytic astrocytoma. And I've included here the atypical pterygoid rhabdoid tumors because up until 15 years ago or so, these patients were mixed in with the medulloblastoma. They have a poor prognosis. In some ways, they changed outcomes in the infant group, suggesting that treatment was not very worthwhile. A more recent look at just the Hospital for Sick Children's epidemiology shows that the embryonal or medulloblastoma tumors are about, in their series, close to 15%. So when one focuses primarily on medulloblastoma, as I mentioned, it's a World Health Organization grade 4 or malignant tumor, but is a treatment-responsive and curative disorder. And the reason why it can be cured is that the treatments involve many modalities, starting with surgery, radiation, and systemic chemotherapy. However, there have been changes in all of these approaches, and I'll bring you up to date. But the major reason we've been able to make such good progress with this tumor group and have such a high cure rate is cooperation. So it's not individual centers working alone, but working together, not only nationally but internationally through groups such as the Children's Oncology Group, the German Consortia, the Pediatric Brain Tumor Consortium in the States, and all of these have made significant contributions to our current management strategies. So this is an MRI scan of a patient, and one can see here, this is the nose, this is left, this is right, and this is the back of the brain where our cerebellum would be, and one can see here this tumor occupying the midline. And when that happens, the cerebrospinal fluid can get backed up, and we can see here early hydrocephalus. And this can also explain why it can take quite a bit of time for a patient to present with symptoms. One can imagine a toddler who has an unsteady gait, and now they're more unsteady, or they're not walking. So that would be a regression of milestones, and an older child being more clumsy or having some morning headaches. But it can take weeks or sometimes months for the symptoms to be severe enough that the patient will be taken for medical attention. This is a sagittal section, and one can see the tumor back here. Now, it's very important that we also get an MRI of the spine, as you'll see later, because the tumor spreads within what we call the neuraxis, the brain and spinal cord, through the cerebral spinal fluid and along the coverings of the brain, the meninges. After the surgery, patients will get a CT scan, and a CT scan can show whether or not there's been any bleeding, but you can see here that the ventricles are a little smaller in size, and the surgery has been quite successful because there's almost no tumor left. It's hard to know if this little area here is tumor edema, and in fact an MRI is better in this regard as long as it's done within the first 48 hours of surgery or approximately 2 weeks later. Between 72 hours and about 11 or 12 days, there can be a lot of artifacts from the surgery, making it hard to distinguish surgical reaction from residual tumor. One of the complications of aggressive surgery that we've seen is something called cerebellar mutism. And this is a complex term because it's not just the cerebellum. And if one looks really hard, the Michigan group looked at children's oncology group data now about 8 years ago and found that if you looked really hard, up to 1 in 4 patients will have some element of cerebellar mutism. What this means essentially is you have a child who had normal communication or speech, and then after the surgery they're not talking, they're not communicating. There may be some other issues as well neurologically, so it may not be isolated. And this can last for weeks to months. There may be gradual improvement. Some of these children do not get quite back to baseline. And so people have been asking whether this is due to the surgery, is it due to the tumor, is it in fact due to the approach to the tumor? In other words, is it how the surgeon's getting at it? And neurosurgeons have looked at various types of surgical approaches which have advantages and disadvantages. They've also looked at other factors such as age and brainstem invasion, and it's still not clear what that is about. More recently, the Hospital for Sick Children group, in collaboration with others, have defined a cortical thalamo cerebellar pathway, or CTC pathway, as you can see here, where you have inputs from the cerebellum going through relay stations in the thalamus to the cerebral cortex, and kind of explaining how there's this connectivity that may be disrupted. And they also looked, very interestingly, whether or not the patient's handedness played a role. It's a very simple thing, but they looked. And surprisingly, they found that those patients who were left-handed were more at risk than those who were right-handed. Now, of course, this needs to be looked at, and we're not suggesting for a moment that left-handed patients shouldn't have surgery or aggressive surgery, but it suggests that they may be at higher risk. And in fact, in this study published almost 2 years ago, they felt that the risk for patients who were left-handed was about 85%. In addition to mutism, some of the patients can have neuropsychological deficits following surgery, and this supports that cerebellum is more than just the center of the brain coordinating movement, and that it really underscores how important this part of the brain is to overall brain function, and again to the interconnectivity of this region with the rest of the brain. So going back to medulloblastoma, what we are trying to do as a field in some ways is emulate our colleagues that focus entirely on leukemia and trying to come up with risk groups. So we do not treat each patient the same as all others, that we assign a risk category and treat patients the same within a risk group. So for what we call average risk medulloblastoma, as you can see, and contemporary survival numbers are about 85%. These are children who are over the age of 3, who've had a very good resection where there's very little residual tumor, and have what's called M0 disease, no evidence of metastatic spread, and I'll explain that further. Those who are high risk, the survival numbers are better than they used to be, but more like 2 and 3. These are patients who have a lot of residual tumor or may have metastatic disease. The infants have not done as well for multiple reasons, and part of that is that we delay, limit, or avoid radiation, which is very important towards the cure of many of these patients. Regardless of how they present, if the patients have recurrent disease, we're still doing very poorly in salvaging. So the best shot at cure is the first shot. So what's happened with therapy for our average risk patients? Well, the most striking change in treatment over the last 10 years has been reduction of the dose to the brain and spinal cord. So even though the patients have tumor in the back of the brain, we treat the entire brain and spinal cord to get rid of microscopic disease that we can't see on the MRI and to prevent seeding in that area. And the usual dose had been 3600 centigrade or 36 gray to the brain and spinal cord. And I'll show you data where it became very clear to investigators that it was safe to reduce the dose to 23.4 gray, but only if you had adjuvant chemotherapy. And current studies are actually looking at whether children less than 8 years of age can get 18 gray, so that's 50% less radiation to the brain and spinal cord. Now this has not come with a reduction of the dose to the tumor itself, which is maintained at around 54 to 55 gray. But the way we give the dose to the local tumor has changed as well, in that 3D or three-dimensional treatment planning using conformal radiation techniques and techniques known as IMRT have played a role. We have to continue to give chemotherapy, especially for reducing the radiation dose. Giving chemotherapy prior to radiation or neoadjuvant remains undefined, and certainly in studies performed in Europe and in isolated North American centers, this has not been shown to be a good strategy. It has not improved outcomes at all. So our overall goal with these average risk patients is to reduce the long-term effects to the hormonal system or neuroendocrine, psychological effects, but also at the same time get very good outcomes, event-free survival or EFS, and overall survival, OS, and without increasing the risk of failure, because if the patient's tumor comes back, as I showed you, the outcomes are very, very poor. So you don't want to dial back the therapy too much because there may be unintended consequences. So as I mentioned, the changes in therapy have not just been reducing overall dose to the brain and spinal cord with the craniospinal radiation. We've made adjustments to how we deliver the dose, and the radiation oncologists have implemented the latest technologies throughout North America and the rest of the world to really treat the tumor bed not as a sphere but as a tumor, and they can contour the dose received to the tumor itself. They can spare the cochlea, so the nerves that regulate hearing are here, and they can be spared, get lower doses, so critical structures are less likely to receive higher doses of radiation. So just dialing back in history to 1996, Dr. Deutsch presented a study which was then followed up 4 years later looking at outcomes, and I'll just give you the punchline. When they reduced the standard dose of craniospinal radiation from 36 gray to 23.4, but no chemotherapy was given to these patients, so these patients are treated only with surgery and radiation, what happened was those patients who had the reduced dose radiation, only half had event-free survival at 8 years compared to 2/3 who had the standard dose. So there's some good news and some bad news here. It's interesting that half the patients can essentially have a long-term cure at 8 years, event-free survival, just with reduced dose radiation. But it also suggests that you're losing a significant portion by reducing the dose of radiation if you don't give chemotherapy. Furthermore, knowing that contemporary survival rates are 85%, it underscores how important chemotherapy is in this combined therapeutic approach. So if you don't give systemic chemotherapy, there's an increase of early relapse, and I already told you that's not good. Early isolated relapse within the brain spinal cord and lower survivals. So this is an example of the first study performed by Dr. Packer and colleagues, published in the Journal of Clinical Oncology, showing that about 80% of patients will survive 5 years by reducing the dose from 36 gray to 23.4 as long as you give them chemotherapy. So that's much better, 80% compared to 50%. And then the subsequent follow-up study, which included lots of patients, showed that the event-free survival and overall survival were over 80%. Excellent by all standards. And this is the survival curves here, event-free survival and overall survival. When event-free survival and overall survival are more or less overlap, that suggests that patients who relapse cannot be salvaged. Whereas if the event-free survival were around 60% and the overall survival were around 80%, that would suggest that one can salvage these patients at recurrence. Now, Tom Merchant at St. Jude did a more limited study looking at, in this case, not just the reduced dose craniospinal radiation, but also conformal radiation. And he had similar event-free survival, showing that instead of radiating the entire posterior fossa, one can just radiate less than that, focusing on the tumor bed, and have good local control. So this was an important advance from the radiation oncology perspective. Now the elephant in the room, unfortunately, is, and why we're reducing the craniospinal dose, is that this is, albeit an old study, now 10 years old, these are IQ scores, and if average intelligence is supposedly 100 IQ points, that IQ tends to fall years after diagnosis, and it's not, as you can see, it's not hitting some sort of steady curve. It continues to fall year after diagnosis. So what we're hoping to do is not only reduce the slope of this line, but in fact have it level off as well with this reduced dose craniospinal radiation. Now that was average risk patients. Now how about the high-risk patients? Dr. Zeltzer looked almost 15 years ago and identified several risk categories. And one was residual tumor. So if the surgeon's unable to get most of the tumor out by eye and then substantiated by a follow-up MRI scan, it shows that there's a risk factor. So 78% with a very good resection, 54% with bulky residual disease. The age seemed to matter as well, and although the curves over 3 years of age seem to overlap, the infants do much worse. And we believe that this is a correlate in part by deferring or avoiding radiation in these patients. The last risk factor, which is very important, is metastatic disease. And this is what is known as a modified Chang scale, where M0 means there's no evidence of metastatic disease, and this includes MRI and spinal fluid, as I'll show you in a moment. M1 means that there is only CSF or spinal fluid involvement, cells circulating, and anything more than M1 means that you can see tumor deposits far away from the original site of the tumor, either in the cranial cavity or in the spine area. That would be M2 and M3, and M4 means the tumor is spread to the rest of the body or systemic metastases. We're seeing a lot less of that. And this is the modified Chang scale, so M0 is no evidence of metastatic disease. M1 means you have positive cerebral spinal fluid, and this cannot be spinal fluid that's taken by the surgeon at the time of the operation. This has to be from a lumbar puncture more than 2 weeks post-operatively, so you're not getting circulating tumor cells. M2 is intracranial dissemination, M3 is intraspinal, and systemic disease is M4. Now, there were 2 important studies that were performed retrospectively out of the St. Jude Hospital that I think really in some ways have been overlooked, and I make it a point to highlight them anytime I give a talk. The first was by Dr. Amar Kajar, who's now the Children's Oncology Group leader for brain tumors, and they compared shunt spinal fluid to lumbar spinal fluid to see if there are any circulating tumor cells. And of interest, they detected malignant circulating spinal fluid cells more likely in the lumbar sample than from the shunt. And in fact, 12 patients would have been called metastatic disease-free if they only looked at the shunt CSF, and they would have been undertreated. So this is important. In the second study, Dr. Fillotti, who's now at the University of Cincinnati, she compared lumbar CSF to spinal MRI. People had advocated saying, well, now we're getting very high-quality spine MRIs. Do we really need to do an LP? Patients have been put through too much already. And she showed that each study on their own can have a false negative rate, meaning they can miss metastatic disease, but if you put them together, you have higher rates of detection. And that's why we continue to insist on doing a lumbar puncture when it's safe to do so, which is usually in the post-operative period about 2 weeks after. One should also do the LP after the MRI, because if you do an MRI following an LP the next day, it can give you artifactual changes which could be worrisome if not interpreted by an expert. So this is what we mean by leptomeningeal disease. We have coating of the spinal cord by tumor. You can see it nicely in these MRIs. Or over here, nodular enhancement. So these are not bones. These are tumor deposits. These are the vertebra here. And you would not expect to see this in a patient with localized disease. So what are we doing with these high-risk patients? Obviously, we cannot reduce the dose of craniospinal radiation anymore in this group because, in fact, we may need to augment therapy. So what we're doing is continue the dose of craniospinal radiation to 36 gray, and in fact, we have to give them more therapy or intensify it. Some groups are taking these patients into high-dose chemotherapy with autologous stem cell rescue. And Dr. Doug Struther, now based at the University of Calgary, Alberta Children's Hospital, did a feasibility study over 10 years ago and showed that this strategy was fine. More recently, the St. Jude group, using their 1996 protocol, showed that this strategy can give the 70% 5-year event-free survival, which is quite good for these high-risk group patients. And right now, there are a couple of competing studies, the Children's Oncology Group and the St. Jude 2012 protocol, looking at how best to treat these patients, building upon prior successes. Clearly, we need to identify the high-risk and very high-risk groups prospectively and treat these patients according to the tumor biology, which I'll get to in a moment. So the Children's Oncology Group is using carboplatin during radiation to improve the efficacy of standard dose of radiation, 36 gray plus a boost to the posterior fossa, and using a vitamin A analog, isotretinoin or cisretinoic acid, during chemotherapy and afterwards to, in some ways, help the tumor differentiate and stop dividing. And the study actually still remains open. Now, what about the infants? In some ways, there's been a bit of a return to radiation in selected groups, and the question is, can one avoid craniospinal and just radiate the involved field? There's also a question of whether or not the rates of surgical removal of these tumors can be improved by what's called second-look surgery, where after a period of chemotherapy, the tumor shrinks somewhat, is more amenable to resection, and the surgeon goes back in to remove what's left. Certainly, a lot of the babies are going on to high-dose chemotherapy with stem cell rescue, and we use the term tandem transplants, where after collecting or harvesting these patients' stem cells, they're given back periodically. So it's not just one dose of high-dose chemotherapy and one reinfusion of their stem cells, but this happens 3 or 4 times depending on the protocol. We're making very sure to exclude patients with atypical teratoid rhabdoid tumors from this group because they really need separate therapy. Unfortunately, about 10 years ago, Dr. Geyer showed that this approach only had a somewhat limited success, with about 1/3 of patients having a 5-year event-free survival. Getting back to the biology as well as the importance of radiation in some of these patients. A very interesting study published also about 10 years ago came from the German group, Dr. Stefan Rutkowski and colleagues, and compared to these results from the children's cancer group, now the children's oncology group, of about 1 in 3 patients having event-free survivals greater than 5 years, they were getting event-free survivals approaching 70%, similar to the high-risk patient groups treated over the age of 3. And I'll show you the rationale for that. And this was occurring only in patients who had average risk disease, albeit in an infant age range. And it's a very complicated protocol, but what these patients were getting in lieu of radiation was a lot of the drug methotrexate, which has been around for quite a while. They were getting it either high dose intravenously, and some of the patients were also getting it interventricularly, meaning delivered into their spinal fluid either through an ammonia reservoir or through lumbar punctures given throughout the course of therapy. And this just shows some of the outcomes in terms of whether or not patients had no residual tumor and no metastatic disease, residual tumor or solid metastases. We've seen these sorts of curves before. But what was also striking was that in their study, there was a large group of patients who had what was known as desmoplastic medulloblastoma, which is a term pathologists use to describe one of the subtypes. And compared to the classic medulloblastoma, here at the bottom, those with desmoplastic did really, really well. And at that time that this paper was published, it wasn't clear what the underlying biological reasons were for this good outcome. But others felt that this study had too many of these cases to really make important conclusions regarding the role of the high-dose methotrexate in this patient group. To me, though, the most important outcome of this study was the following. And this is a very, very busy slide, but I just want to draw your attention. On your right here, you'll see IQ scores, and 100 is sort of average. And if one looks over here on your left, these are the patients who would have what I would call the works. They would get surgery, they would get chemotherapy given in the blood as well as into the spinal fluid, and they would also get radiation. And you can see here the IQ scores. Don't look at this number here, but if you go over to the IQ, they're in the 75 range. So that's a big drop from the average. Yet if you remove the interventricular chemotherapy, you can see here that the IQ scores improve. If you remove the radiation alone, the IQs continue to improve. And then if the patients only get systemic chemotherapy, there really is almost no statistical significant difference between this group and this group, the control group who've not had any therapy at all. And this, to me, was a very nice study showing that as we add in more and more types of therapy, interventricular chemotherapy, radiation, or the combination, that one continues to see effects on this vulnerable group of patients who have a developing central nervous system. So on to the next group. After average, high risk, or infant therapy, we do see recurrent disease. And at the moment, people are taking these patients to high-dose chemotherapy, that's HDCT, and autologous stem cell rescue. And the best candidates for this approach have an isolated local relapse where the surgeon can reoperate, and hopefully what we call minimal residual disease at the time of high-dose chemotherapy. And there are many different regimens. Other patients are being taken on to phase 1 studies with new drugs, or phase 2 studies where the dose for the drug has been determined by phase 1, and they're looking for things such as response rates. But there really is no standard treatment of choice yet for recurrent disease, and I think a lot of it's going to depend on the underlying biology or the reason for the relapse in the first place. And there's some groups in Toronto and elsewhere that are putting a lot of time and effort into understanding the difference between metastatic and relapse disease from initial. And we're going to see some major changes in how we treat these patients over the next 5 to 10 years. Now, I did mention at the beginning of my talk that medulloblastoma can occur in adults. And although this only represents 2% of adult brain tumors, it represents up to 20 or 25% of all medulloblastomas when taken together. So there are some differences, though, and some of this can be explained by the biology, which I'll show you in subsequent slides. What we do notice in adults is that the course is a little more indolent, meaning it tends to come up a little more slowly, and it also tends to linger, and it may not be as easy to cure. The tumor often presents in a different part of the cerebellum. I mentioned earlier in children it's often a midline disease, and then can present late. When it's in the sort of the side, the patients can present with movement that's a little clumsy on one side compared to the other. They may actually present with hearing loss, and this is not an uncommon presentation where a patient will say, you know, I'm not hearing as well, go to an audiologist or see an ENT surgeon, and it can take months before someone orders an MRI and the tumor is found. The desmoplastic histology that showed favorable outcome in the German study may often be seen in adults. Because the tumors are lateral, they're often hard to completely resect. We often see some late relapses. In my clinical practice, I saw a patient who presented 17 years after his initial therapy. And I've heard of others who've had patients more than 20 years after the initial surgery, the tumor coming back. So that is what we would consider a late relapse. The main problem in the adult group is that they do not tolerate treatment that we give children, as you'll see in a moment, and they often will stop therapy, not because they don't want to be cured, but because the treatment in some ways to them is worse than the disease itself. So I did mention that under the microscope, the pathologist can diagnose medulloblastoma, and this is an example of what we call the classic subtype, and all of these are grade 4, as you may gather, not all malignant brain tumors behave the same way clinically. So the classic, so essentially we call these small round blue cell tumors because we only see the nucleus of the cell. There's very little cytoplasm, there's very little organization, although one can see here some attempt to form a rosette, like a circular structure. But there are 3 other types of desmoplastic, as I mentioned before, the large cell and anaplastic. And this is an example of the desmoplastic. So here would be sort of the classic part of the tumor, and then you see these sort of harder areas that are less cellular and more nodular. And there are variants that are actually very nodular, and they have a much better outcome. This is the anaplastic large cell medulloblastoma, and the cells are much larger, and many of them have expressed something called c-MYC, which is an oncogene. And this has been borne out in the more modern studies. This study was published almost 15 years ago. So how have we learned so much about the biology of these tumors? Well, it's actually been due to technological advances in the lab in order to do studies that we could have only imagined 20 years ago. And this has to do with what we call microarray technology. And although it's rather complicated and expensive, nowadays, these sorts of experiments can be done by using a kit and performed in a lab in an afternoon. Quite something. The general idea is to compare A to B. So you can compare disease 1 to disease 2. You could compare normal to tumor. Depends what you want to compare. And you simply label the RNA or DNA, depending on what you're studying, with a colored probe, colored fluorescently. And you have the RNA or DNA labeled in one direction for one sample and the other direction for the other. What I mean by direction is 5', 3' is the usual way that DNA is transcribed, and so you can make a label that goes in that direction, or you can label the opposing strand, which is 3', 5'. And essentially, when you hybridize these probes to the sample, areas that are commonly expressed, let's say red and green together would be yellow, would maybe not be that interesting, or you could be interested in genes that are expressed more highly in the tumor or more highly in the normal structures, and then you can drill down to the details. So what you're trying to do in an unbiased fashion is really get a sense of what's happening at the level of gene expression in one condition versus another. It's very powerful technology. So Dr. Pomeroy, who's a pediatric neurologist at Harvard, published this very important paper in Nature about 12 years ago. And this is a very complex slide, and this just shows you what the medulloblastoma looks like. And this is an example of what we call a heat map, where if something is being overexpressed, it would be red or hot, and if it's underexpressed, it'd be blue or cold. And then essentially, the computer is asked to sort out the samples using a computer algorithm rather than by having human input. So this is known as unbiased approach. And the computer itself decided to bin these patients into 5 groups. Some medulloblastomas all sort of bin together. And here's another one called the rhabdomyosarcoma that's sort of bin together. It's not entirely perfect, and each line of these is a particular gene. So without really going into any of the details, the computer can distinguish almost as well, or some would argue even better than a pathologist, in which type of tumor is being seen. So that's really neat. You can take it further, and in the same paper, Dr. Pomeroy's group was able to, using this algorithm, show that classic medulloblastoma has a different gene expression signature than desmoplastic, and that's important. He could distinguish patients who survive from patients who didn't, based upon their gene expression, although it was a little, the data wasn't as clean, it was still statistically significant. And finally, in a competing study by Toby McDonald in Nature Genetics a year later, you could distinguish metastatic disease from non-metastatic. And this was the first time that we had something other than pathology and an MRI scan or spinal fluid samples to help us understand biology of these tumors and why there are differences in outcomes. So one can then take that information, the gene expression, and compare it to the things we knew about before, such as metastatic disease, the histology, or the sex of the patient. Now, this was a small study, but clearly the gene expression pattern, the low-risk gene pattern, was as predictive as whether or not a patient had M0 or lack of metastatic disease. And in fact, if you take the low-risk pattern, absence of metastatic disease together, it's very predictive of an excellent outcome, here 85% or better. Yet if you have a high-risk gene pattern or metastatic disease combined, patients did very poorly. So we're not replacing our clinical parameters, we're adding on the molecular or gene expression signatures and getting much better prediction information. So just to sum up this part of the talk, medulloblastoma, the goal has been to achieve a maximal safe resection, reduce tumor burden, and surgeons have been perhaps changing their surgical approach to reduce the incidence of cerebellar mutism. Overall, in the average risk patients, we're reducing the dose of craniospinal radiation from 36 gray to 23.4, and what we're trying to do is reduce the toxicities attributed to radiation and to the developing brain. But if we're doing that, we also have to make sure we give chemotherapy. And then the radiation to the involved field has included innovations in treatment planning, conformal radiation to the shape of the tumor, and sparing critical structures. Now, I did mention that adults don't tolerate the chemotherapy and often abandon adjuvant chemotherapy, but we actually see in the second decade of life, so the teenagers don't do very well either with the therapy, although they still do very well with their disease. So the Canadian Pediatric Brain Tumor Consortium looked at about 70 patients, and about half were standard risk. And overall, these patients had a pretty good survival, approaching 80%, but lots of toxicity from treatment. Hearing loss in almost half, neurotoxicity, nerve damage from some of the chemotherapy, hematotoxicity, which could delay treatment, but we usually recover. But the most important thing was patients were losing weight, failing to thrive, and often required feeding interventions with nasogastric tube feeding or G-tubes, and we had to often reduce the dose, and up to 25% had to stop the protocol. And one has to argue that this group of patients doesn't tolerate the therapy, and there may be other interventions we have to consider, such as perhaps using a shorter course of therapy, and this perhaps has contributed to the popularity of the high-dose chemotherapy, the stem cell rescue approach, which shortens the overall course of therapy, although during the time they're being treated, it's still quite toxic. The other thing that was interesting is that in this second decade of life, we do see late relapses similar to what we see in the adults. And although these late relapses are shorter than we see in the adult group. So what's become all the rage now in cancer chemotherapy as well as in treatment for other diseases in children or adults is to personalize therapy. In other words, not only should we put patients in the risk groups, maybe we should, within the risk groups, each patient should in some ways get their own treatment plan. And although we do that to a case, it's still an evolving concept as we incorporate advances in tumor biology into our treatment strategies. So this is the concept here, is that you can, this is a slide I adapted from Stephen Yip, who's a neuropathologist from BC Cancer Agency, is here you've got a patient with medulloblastoma. If their tumor had mutation A, and you give them a specific treatment for mutation A, it will help most of those patients. However, if you give that targeted therapy to all patients, regardless of which mutation they have, you may only help 1 in 10. So we really need to pick the patients who are most likely to benefit from the special therapy. And sometimes it's very hard to explain this to families why we're not going to offer a particular therapy for them or their child when it's clear that one size does not fit all. So these targeted therapies should be given to patients for which it makes sense to give them the treatment. So a seminal discovery which has really changed the way we now think of medulloblastoma was published out of Mike Taylor's lab, and the lead author is Paul Northcott, and it was published in the Journal of Clinical Oncology just 4 years ago. And they used newer microarray technology to put patient groups for medulloblastoma into categories. And the computer itself, without any bias, so this is unbiased clustering, put medulloblastomas into 4 groups. And their names I'll explain in a moment. One is called the Wnt group, one is called the sonic hedgehog group, or SHH, one they called unimaginatively group C, and the other one group D. And as you'll see, and they also tried to link clinical variables as well, patient's age, their sex, and the tumor histology, as well as some well-known genes and chromosome signatures which people had used in the past sort of as key tests without looking at the overall picture. And the computer, as you can see, this is sort of a 3D binning diagram, shows that the Wnt group is distinct from the sonic hedgehog group, and the group C and D are distinct from the other two, but there's a bit of overlap. And surprise, no surprise here, the group that does the worst in terms of outcome is actually the group D and group C. And one can look at using this gene signature, and you can see that the Wnt subgroup, which is least common, occurs throughout the childhood age range with a peak at around age 10. The group C patients peak sort of in earlier childhood and fall off in the teenage years. The group D patients sort of peak in late childhood and then fall off. And the sonic hedgehog group is interesting in that it's quite prevalent in the infants as well as in the adults. And this is another way to look at their data based upon the age group. The most common group in the infants is the sonic hedgehog group, and in the adults as well. But in the children, one sees really a mix of all 4 different groups. Of interest to me is that each of these groups, including the best prognosis Wnt, have metastatic disease, suggesting that metastatic disease itself does not portend always the worst prognosis, and one has to have much more information. What was really exciting from this study, although it's been hard to implement in clinical labs, is just using 1 or 2 antibodies. The pathologist could then say a patient who's a Wnt subgroup or sonic hedgehog group or group C or group D. And although these antibodies have not worked well across all labs, the beta-catenin one has now been universally adopted. And this is important as we try to now treat, remember, these are all World Health Organization grade 4 tumors, and give them more specific therapies based upon their tumor biology. And what was striking in this paper was using these antibodies, they were able to get similar distributions of the sonic hedgehog, Wnt, and group C and group D. And if you look at this curve and compare it to the curve used by gene expression, you can see that just using a few antibodies, which is much less expensive, one can almost replicate the more expensive gene expression studies and put these patients into the 4 groups. So what does this mean? Well, clinically, as you can see here, the Wnt patients almost have 100% survival, and that's striking. Sonic hedgehog are getting reasonable survivals, 85%, and then the group D, not bad but not great, and the group C do very, very poorly. So this suggests that maybe these Wnt patients are being overtreated, and we could perhaps dial back the therapy. Maybe these patients don't need radiation to the brain spinal cord. Maybe they'll do fine just with radiation to the involved field. Whereas the group C patients, regardless of their risk group using the former classification scheme, maybe we really need to step up and change their therapies. And this is a slide that no one wants to see, let alone the audience to which I'm speaking, but it's supposed to show a cell, and this is the cytoplasm, and this is the nucleus, plasma membrane, and outside. But just to mention these terms, Wnt and sonic hedgehog, these are cell signaling pathways that are used during development, and cancer cells can co-opt them. And so if you have mutations, things can change. And the way I would think about it is if you have a mutation, it can lead to unfettered growth, proliferation, and prevent differentiation. So these cells continue to divide and become larger tumors, can invade and spread to other parts of the brain and spinal cord. So at the end of 2012, Dr. Taylor and other groups decided, because there were many papers from different groups that all more or less have the same overall conclusions, that there were several molecular subgroups of medulloblastoma, and they put their heads together and came up with a unified classification scheme, still using the Wnt, sonic hedgehog, group 3 and group 4. And they included the age groups, the gender, clinical features that we've used for years, as well as the cytogenetics and gene expression, and trying to come up with a unified classification scheme. And the reason for this is that everyone can now talk about the same classification scheme, and clinical trials can be designed to incorporate this information. So a couple things we've learned subsequent to the scheme, and if we just look at the sonic hedgehog group, people have found there's some patients who do really, really well, but others do quite poorly. And in another paper just last year in Journal of Clinical Oncology, it showed that patients who have mutant P53, which is a tumor suppressor gene involved in many types of cancers, not just brain tumors, do quite poorly. And this is quite common in the sonic hedgehog group. Of interest, it's also seen in the Wnt patient subgroup, for which most of these patients have a good prognosis. So others have now said, well, how are we going to use this information going forward? I mean, we're still going to see a patient, here's an infant, we're going to make a diagnosis, the pathologist is going to get it, and this neuropathologist is saying the patient has a desmoplastic or multinodular medulloblastoma, maybe they should just go on a low-risk protocol. But if they have a non-desmoplastic medulloblastoma and they have metastatic disease, they should be high risk, and if there's no evidence of metastatic disease, in other words, standard risk, they would go on to a standard risk protocol. He's saying for children, and again, this is just right now a scheme to consider that after you make the diagnosis, if you have a patient that we would previously call standard risk, that means no metastatic disease, no residual disease, and they have classic pathology or desmoplastic, then if they're a Wnt, they would go a low-risk protocol, and if they're sonic hedgehog, they might go on a standard risk protocol plus a specific blocker to that signaling pathway, and there are drugs available. And similarly, if they have high-risk disease, they may get a sonic hedgehog or high-risk protocol. So we're going to different risk-based strategies incorporating this molecular and genetic information. Here's another way to look at it, incorporating the P53. So if you have a subgroup, if you're Wnt group 3 and 4, you treat as per the local protocol. But if you're in the sonic and you have a mutant P53, you have a very bad outcome, and we're going to consider different therapy than if you're wild type, or you would just use a more standard protocol. So we're just drilling down, and we're now not lumping patients together, but we're splitting them off into different groups, and we're going from 3 risk categories to multiple ones, heading towards individualized or personalized therapy. So future cooperative group studies will stratify patients on the basis of the clinical markers we've used for years and these new molecular markers, and drugs that target specific groups within this will be used and added to therapy to maximize survival, minimize toxicity, and optimize outcomes and quality of life. Because we know that if we have a survivor of childhood cancer who's lost many IQ points and cannot complete their education or join the workforce, that we may have a success in terms of outcome, survive or not survive, but we really don't have a success from a quality of life perspective, and that's so important. Now, the last couple of minutes, I'm just going to talk about high-dose chemotherapies or megatherapy. And certainly people would agree in the field, although there have been few, if any, randomized studies, that infants that diagnosed with medulloblastoma, because we would like to avoid radiation, could be considered for megatherapy. Those with recurrent disease also. And I would say, and not everyone agrees with me, that average risk patients can do very well with standard therapies, and until standard therapies compared to high-dose chemotherapy and stem cell rescue in this group, in some ways it's a dealer preference or local preference based upon the institution. If there's an open clinical trial, we should support that. Patients who have PNETs, atypical teratoid rhabdoid tumors, choroid plexus carcinomas, and some germ cell tumors with recurrent disease are also considered reasonable candidates for megatherapy. The St. Jude protocol uses a risk-adapted craniospinal radiotherapy followed by the high-dose chemotherapy and stem cell rescue, and you can see those patients with average risk or high-risk disease do quite well. The average risk patients don't really do any better than the children's oncology group, but they may have different toxicity profiles. And the high-risk patients certainly have better outcomes than we've seen in more historical studies. And the other thing that I think is worthwhile noting is that, let's say in the second decade of life, where 75% would complete, they're having a higher completion rate, suggesting that a shorter protocol may be better tolerated by some patients. There are some limitations for high-dose chemotherapy that are apparent to many of us in the field. The drugs we give have to cross the blood-brain barrier to get at the tumor. There are some toxicities of high-dose chemotherapy that may not be reversible. And because of improvements in surgery, radiation, supportive care, we can't just attribute all good things to high-dose therapy and stem cell rescue. There have been other improvements that have occurred contemporaneously. Now, another elephant in the room is proton radiotherapy. Many centers are sending children with medulloblastoma for protons, not because protons are better, but because the craniospinal field, if offered, will have less scatter to organs outside the spine, meaning that doses potentially the kidney, bladder, rectum, etc. are going to be lower. But the proton therapy itself is not better in terms of cure, but it's to reduce toxicities outside the brain spinal cord. And we certainly know that radiation is important for local disease control, and that's coming back into infant protocols. We know that some tumors are chemo-resistant, so more isn't necessarily better. And sometimes it's hard to achieve minimal residual disease because patients' tumors are essentially inoperable, or they're in areas of the brain that you just cannot remove because they're so important, such as for learning, memory, vision, etc. I've just spent a lot of time telling you that tumor biology really means that we're dealing with many different genetic disorders, and the molecular biology is going to help us better identify candidates. And my problem as a clinician investigator is the lack of randomized studies to compare high-dose chemotherapies to standard of care to really know for sure that it's making a difference. So with that, I'd like to end my presentation. It's been a pleasure speaking to you on behalf of the Brain Tumor Foundation of Canada. I'm available for any questions via email. Note the spelling of my last name and my email are not the same. The last letter has been dropped, so it's eisensta@ualberta.ca. And I welcome any of your questions or comments. Thank you very much.
Thank you so much, Dr. Eisenstadt. What a great presentation and great information. And thank you for joining us today and taking time out of your busy schedule to present information on medulloblastomas. It's clear that there's a lot of great research happening and lots of great information out there for patients and families and healthcare professionals. And you always present information in a way that is easy to understand, and we appreciate your expertise and insights into this area of neuro-oncology. So thanks again for taking time out of your schedule.
Oh, you're welcome. Thank you very much for the invitation.